Thank you, everybody. We're ready to get started. I'm pleased to introduce Dr. Kip Talbot, who's chair of the ACIP Influenza's work group. So please go ahead and give us an introduction and overview.
Okay, super excited to talk about flu. Okay, I am. All right, next slide. Okay, I have an awesome group that I work with. Other ACIP members include Camille Cotton and Jamie Lair, and then we have a large number of ex officio and liaison representatives. Thank you. Next. Oh. All right, so we've been busy. As many of you know, I think everybody's been busy. But anyway, so there's been the completion of the 2022-23 influenza vaccination recommendations, and those can be found in the MMWR. And then we've had discussions of U.S. and Southern Hemisphere seasonal influenza activity, like RSV. It's been an upside down kind of year. We've talked about U.S. influenza vaccine effectiveness updates from the 3 CDC networks, and we've also talked about influenza vaccination and pregnancy. And so today, we're going to talk about clinical trial data to compare safety of the recombinant influenza vaccine versus the inactivated vaccine in pregnancy. And Dr. Geeta Swami from Duke will be joining us to discuss that. We're going to have influenza activity updates, also one of my favorite topics, from Ms. Lynette Brammer and Dr. Pareen Mersenak. I should have asked beforehand. My apologies. And then we'll talk about influenza vaccine effectiveness. And Ms. Jessie Chung, Ms. Samantha Olson, and Dr. Lewis will be joining us for those. So next slide. All right. Dr. Swami, are you ready?
Good afternoon.
Great. Thank you.
I think Dr. Grosskopf is going to be pulling the slides up and advancing them. All right, I'll go ahead and get started. I know that everyone's time is short, so thank you for the opportunity and the invitation to present some of the results from our study that was funded by the Clinical Immunization Safety Assessment through the CDC. And we're going to be talking about data from our randomized trial to look at the safety of recombinant influenza vaccine versus a standard inactivated influenza vaccine, both quadrivalent during pregnancy. Next slide. This is just a disclaimer to note that the findings and conclusions are those that I'm presenting here, not necessarily the official position of the CDC. And I mentioned the funding support as well. Next slide. These are my personal disclosures to note that I do serve on DSMBs and have consulted for vaccine companies in clinical trial design. Do have funding from the CDC, as well as serve on various committees for our advocacy organizations and federal advisory committees. Next slide. So just a quick point of rationale for why we were looking to conduct this study. So as you all know, that we currently recommend influenza vaccine for anyone ages 6 months and above, including pregnant women. And we wanted to look at whether there was any difference between the standard inactivated vaccine and the recombinant vaccine or flu block. Pre-licensure studies for the recombinant vaccine excluded pregnant people. And while there's no specific reason to expect that it would be unsafe, there really is no data looking in a systematic way at the safety of recombinant influenza vaccine in pregnancy. So we felt that a rigorously implemented randomized controlled trial would help to provide some of that information, both on the safety during pregnancy as well as infant health outcomes. Next slide. So the primary objective of the study was to look at adverse birth outcomes between the two groups, individuals randomized to recombinant versus standard inactivated, with a hypothesis using a non-inferiority study design that the birth outcomes in the group receiving the recombinant vaccine would be no higher or no worse than those receiving the standard influenza vaccine. Next slide. Additional secondary outcomes were to then take each of the component factors from that composite outcome of looking at adverse birth outcomes and look at them individually. Those component parts are preterm birth, defined as less than 37 weeks gestation at the time of delivery, looking at fetal deaths as well as neonatal deaths, looking at spontaneous abortion or early pregnancy loss, and then also looking at local and systemic reactogenicity, looking at comparison of moderate to severe responses following each of the vaccines. Next slide. So we enrolled individuals into this prospective double-blinded randomized trial where subjects were randomized 1-to-1. We had enrolled 382 pregnant women, all adults who were less than or equal to 34 weeks gestation. Our goal was actually to enroll about 430, but there were things that curbed the enrollment time period. We also again, we're looking at the less than 34 weeks, not because of anything related to safety or concern, but to actually be able to have adequate time to follow the pregnancy and to then see whether there were any impact on outcomes. Subjects were recruited across the 3 sites in our CISA-funded study at Duke, at Cincinnati Children's, and at Boston Medical Center. Next slide. So after randomization, participants received one of the 2 vaccines, again, in a double-blind fashion. We collected data on local and systemic reactions starting on vaccination day through day 8, using a memory aid that was provided to them that they could then provide the information back through REDCap electronic data or record that on paper and provide that information to us either in person or over the phone. Serious adverse events and other outcomes were followed through the course of pregnancy and 90 days following delivery. We did collect samples to look at immunogenicity both on day of vaccination as well as approximately 4 weeks post-vaccination. We collected maternal samples and cord blood samples during the delivery hospitalization whenever feasible as well. Next slide. So I mentioned this a bit earlier, but the primary outcome measure was defined as adverse birth outcome that was a composite, including preterm birth, spontaneous abortion, fetal death, or neonatal death. Next slide. And similarly, for the secondary outcome measures, we looked at preterm birth, a combination of fetal and neonatal death, a spontaneous abortion alone, and then the local and systemic reactogenicity events. And all of the outcome measures were assessed in our modified intent to treat population, which I'll describe, I think, on the next slide. Yes, so the modified ITT population were any participants that were enrolled, randomized into the study, and received study product. We also had a per protocol population, which was a subset of those that excluded participants who had any serious protocol violations. Statistical testing was done from a non-inferiority analysis approach with the upper bound of the stratified through Newcomb binomial confidence intervals with a Cochran-Mantel-Hansel weighting those differences. We did look at other comparisons as well, and you'll see those. Next slide. So following our enrollment of participants, you can see that we approached 430 participants. 387 of those were screened. 3 were determined to be, apologies. So we had 430 participants as our target, but 387 were screened, 3 then ineligible, and none of those that were actually screened declined. So we had 384 who were enrolled and randomized. There were 2 who were excluded for eligibility criteria that were identified to be incorrect or not assessed correctly from the start. So there were, as you can see, randomized in the modified intent to treat, 190 that received Flublok, 192 that received Fluvaval. And then you can see there were some withdrawals and loss to follow-up based on lack of delivery data, as well as another participant who did not meet eligibility criteria that was identified following randomization. So the end result was based on 188 participants in the Flublok group and 187 in the Fluvaval group. Next slide. So demographic data was fairly consistent between the two study groups. We had about 33% of our participants as self-reported Black race, and the remaining you can see here. There was, again, by self-report, about 12 to 13% of participants identifying as Hispanic or Latino ethnicity. About 34% to 40% in each of the two groups were enrolled prior to 20 weeks gestation. And we were deliberate in enrolling individuals early in pregnancy to be able to have participants that we could monitor for that spontaneous abortion early pregnancy outcome. Gestational age at enrollment was roughly around 22 to 23 weeks. Next slide. So in looking specifically at the primary outcome, again, the proportion of adverse birth outcome is based on that composite definition. You can see that there was approximately 9% in the flu block recombinant group and about 11% in the flu-Laval standard inactivated vaccine. So this, the null hypothesis of inferiority was rejected, so that the rate of adverse birth outcomes in the recombinant influenza vaccine group is considered not worse or not higher than that of the standard inactivated group. Next slide. Then breaking that down into each of the component outcomes, you can see here for preterm birth that there was about 7.5% preterm birth incidence in the flu block group and about 10% in the flu-Laval group. That was not also not statistically different. Next slide. Combining fetal and neonatal deaths, but important to note, there were no neonatal deaths. There were 2 fetal deaths that occurred in the recombinant vaccine group, 0 in the flu-Laval group. But as you, without having any events, that's something that's not estimable from the standpoint of comparison, but would not be any higher than we would expect based on background as well. And then looking at spontaneous abortion, again, that early pregnancy loss, we looked at that amongst only the participants that enrolled prior to 20 weeks gestation. And you can see here again that there was really no difference between the two groups. Next slide. So then if we looked at the local moderate to severe reactions amongst the two groups, the blue bars are the flu block group and the red bars are the flu-Laval group. Swelling was not identified in any participants, so there are no bars present. But you can see here that while it does graphically look that there was maybe a bit higher on the tenderness, that was not statistically different between the two groups. Next slide is going to be the systemic moderate to severe reactions. And similarly, there was no fever identified. Participants were given a thermometer as part of study procedures and were asked to record their temperatures. So there was no recorded fever and no note of significant numbers of chills. You can see here there was a few percent, or a little around 1.5% or so in each group, but no difference between them. Again, looking just graphically, it would appear that there was a higher incidence of headache amongst those in the flu-Laval group than the flu-Bot group, but again, that did not achieve statistically significant difference. Next slide. So we did also look at some exploratory outcomes as well. One of the things was to look at maternal serious adverse events. And you can see here listed, this is all maternal SAEs by group. And again, no difference between the two groups receiving the flu block or flu-Laval vaccines. And all SAEs were deemed not related to vaccine as judged by the study investigators. I've listed here essentially what the categories or the diagnoses were for the majority of participants. Many were antenatal hospitalizations, including common pregnancy conditions such as preeclampsia, preterm labor, premature rupture of membranes, hyperemesis, substance use, end-stage renal disease, and some sort of vaginal bleeding. And in the postpartum hospitalization that occurred, again, it was for preeclampsia or some sort of postoperative infection. Next slide. Additional exploratory outcomes were also no different between groups, but you can see here we looked at small for gestational age or fetal growth restriction, defined as less than the 10th percentile of birth weight by gestational age. We looked at clinical chorioamnionitis, which did utilize the diagnostic criteria of fever plus additional signs of clinical chorio. And then we also looked at preeclampsia or eclampsia amongst the groups, and you can see there were no differences here either. Next slide. And then we also looked at serious adverse events among the infants and followed them out again to that 90 days of life. All SAEs here were also deemed not related to vaccination as judged by the study investigators. There were some other serious adverse events such as medically attended events like respiratory infection or whatnot. But I listed here for you the congenital malformations, as that's something that is often of interest to many individuals thinking about enrolling participants during pregnancy. And there was no pattern. There were really only, as expected based on background, several highly common, unfortunately, highly common congenital malformations as they go with regards to renal anomalies, a case of trisomy 21, VSD, renal abnormality and absent thyroid, all in one individual infant, and then the other things that you can see listed here. Next slide. So in summary, this was to date we think one of the first or maybe first randomized trial to look at the safety of recombinant influenza vaccine versus standard inactivated, both quadrivalent dosing. We enrolled 382 participants, which was 89% of our targeted goal enrollment. We were able to demonstrate that recombinant influenza vaccine is not inferior to a standard inactivated vaccine with regards to adverse birth outcomes, which was consistent with our study hypothesis. The safety profile for both vaccines appears similar for moderate to severe reactogenicity events, as well as maternal and infant health outcomes. So from the standpoint of safety, the study would support the ACIP's recommendation to include recombinant influenza vaccine as an option for pregnant individuals. I did mention that we collected blood samples at baseline following vaccination and then at delivery. And so those analyses, preliminary analyses have been done, and we're just reviewing all of those to finalize analyses there. So that is also in progress. And I think the next slide is the last slide to just acknowledge the tremendous number of people who've contributed to this study across all of our study centers, as well as our CDC colleagues and collaborators. So thank you all.
Thank you very much, Dr. Swami, for that presentation. This presentation is now open for questions. Dr. Paling.
Dr. Swami, thank you for a great presentation. One of the questions I'd like to ask you is, did any of the infants of the pregnant women that were vaccinated during pregnancy, were they hospitalized with an influenza illness or had a diagnosis of influenza in the subsequent 6 months? Thank you.
Yeah, absolutely. We didn't do any active surveillance for respiratory infection, but there were no hospitalizations specifically for influenza infection.
Thank you. Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I just want to thank you so much for this research. It's just so incredibly beautiful to look at. And I did have a question. You had, in the congenital anomalies that were found, was one of them your fetal death or no?
You know what? That's actually a very good question, and I should know that. But I am not, I'm blanking on that, but I could find that out and pass that along to Dr. Groskopf to give you all as the working groups and whatnot as well.
Okay.
Thank you for that question. I just don't have it right on the front of my memory.
I think it would be good to say if it was,
yes,
if the fetal death was related to a malformation, that would be great. And will you be publishing this?
Yes, ma'am.
Great.
That is our intent for sure.
Thank you so much.
Mm-hmm.
Dr. Paling.
I've got one more question for you. I was doing some mental calculations as you were going through, and the background rate of each of the outcomes seemed to be in the expected. And I would like to, for each of your different outcomes, and I wanted to verify that I was doing my math appropriately. Thank you.
Yes, so I think you mean for the individual sort of pregnancy complications, is that right?
Yes, ma'am.
Yes. So yes. So in the United States, preterm birth ranges somewhere around 10 to up to or so 15%, depending on group. So ours, depending on various risk factors and so forth. So yes, we saw a rate around 7.5 to 10% between the two groups, and certainly the outcomes related to fetal death and spontaneous abortion would be comparable as well.
And the prevalence of identified fetal anomaly also was in the consistent with the national rates, if I was doing my math correctly.
Yes, that is correct. That's correct. We expect a background rate somewhere around, a few percent of all live births as well. And so I think the point that Ms. Hayes brought up is a good one to look at what our fetal death was, if it was related to those as well. But yes, all of those would be consistent with background rates, including the things related to the exploratory outcomes. For example, preeclampsia or eclampsia was around 6 to 7%. You'll see things quoted anywhere from, say, 4 to 8%, depending on population and so forth.
Thank you so much. Just a brief comment to state that while we know that these background rates do occur, I think it is really helpful to have them on these slides, just because I want to make sure that the public can interpret these slides in context of what background rates are. Since you had such a nice comparison group of an activated vaccine, and we didn't necessarily have a placebo in this instance, I just think that's helpful for interpretation. Ms. McNally?
Thank you. Can we go back to slide 13? My question is whether the race and ethnicity representation here is what you were hoping to have and whether it's consistent with other vaccination and pregnancy studies. Thank you.
Thank you for the question. So we didn't actually set a target goal for enrollment by race and ethnicity. But I will say that I think these numbers are comparable or are proportional to what our populations are at our clinical sites. I can speak specifically for Duke that we generally see, apologies if you can hear a siren outside my door, that we usually see somewhere close to around anywhere from 25 to 40% of our participants, of our patients identify as Black race, depending on variation across our clinics. And I know that in particular, the site at Boston has a very similar demographic and patient profile to what we have as well.
Thank you.
Thank you.
And with that, we will move on to our next speaker, which I believe is Ms. Brammer and Dr. Marcinak, speaking about the influenza activity update. So if we could please bring up their slides. Thank you.
Okay. Good afternoon. This afternoon, I'd like to present on influenza activity that occurred here in the U.S. over the summer and during the first week of the 2022-23 influenza season. Next slide, please. Thank you. This slide shows our virologic surveillance data. On the left is data from clinical laboratories. The yellow shows influenza A viruses. The green, which is very small, shows influenza B viruses. And the line is the percent of specimens testing positive for influenza. You can see we had the late season last year, and activity continued through the summer, and we've, in recent weeks, have seen an increase during the first week of this new influenza season. 3.3% of all specimens tested and reported to us from clinical laboratories were positive for influenza. If you look on, and I wanted to mention that this did vary quite a bit by HHS region. The range was from 0.2% in Region 8, which is the mountain region, to 10.4% in Region 4, which is the southeast. On the right, you can see data from our public health laboratories that show the viruses identified by subtype. The red is influenza A, H3N2 viruses. The yellow are influenza A viruses that have not yet been subtyped, and it's very hard to see, but the orange is influenza A H1N1 viruses. We have seen predominantly H3N2 viruses, but in recent weeks we've seen a small increase in influenza A H1N1 viruses, and the pie chart there just shows the breakdown of viruses for week 40. Next slide, please. Moving on to outpatient visits for respiratory illness reported by the U.S. Outpatient Influenza-like Illness Surveillance Network, or ILI-NET. You can see on the left, this is the percent of patient visits for ILI. It's hard to see, but the red triangle, right, for week 40 is our first week. We actually began the season above our baseline. The percentage last week was 2.6 compared to our baseline of 2.5%. We do always try and emphasize the fact that this is influenza-like illness, not laboratory-confirmed influenza. And as always, it is a mix of respiratory viruses, but if you look on the right-hand side, that's ILI activity levels by state. And these do seem to correspond pretty well with the areas where we are seeing our higher percentage of specimens testing positive for influenza. Next slide, please. This is data from one of our new surveillance systems that we picked up during the COVID pandemic. This is the percent of long-term care facilities with at least one confirmed influenza positive test among residents. Last year, during a relatively mild influenza season, it peaked at 1.4% of facilities having a positive influenza case in a resident. And this year, we're starting to see a very slow increase, but it's right now, for week 40, it's at 0.3% of facilities having a flu positives among residents. Next slide, please. This is our second new surveillance system that we picked up during the pandemic. This is reports from hospitals, all hospitals across the country, of the number of admissions for laboratory-confirmed influenza for that week. During last season, it peaked in April at 3,481 hospitalizations during that week. And in recent weeks, we are seeing an increase. And for the week ending October 8th, it was 1,322. And I will say that in our report tomorrow, that increase is going to continue. Next slide, please. I didn't include the NCHS all-age mortality because we're not seeing anything unusual in there, anything different than what we would expect for this time of year. But I did want to give an update on the influenza-associated pediatric deaths that we saw last year. The total so far is now 43 influenza-associated deaths in children. All of these viruses were influenza A with the exception of 2 influenza B viruses. And the most recent death reported by date of death was for week 33, which was mid-August. Next slide, please. Just to summarize, influenza activity in the U.S. remains fairly low overall, but we are seeing increase, particularly in the southeast and south central part of the country. The numbers are small so far, but H3N2 viruses are predominant in the U.S., and it is, of course, too early to tell what will be the predominant virus for the season. For the sake of time, I moved the slide to the supplemental slides for the Southern Hemisphere vaccine decision, but they did update the H1N1 component. It is within the same genetic subclade that our vaccine is. So the components of our 2022-23 Northern Hemisphere vaccine at this time look appropriate for this season. In other words, similar to the genetic groups of the viruses that we're finding. And that's all I have, so I'll turn it over to my colleague, and we'll take questions for both of us at the end.
Good afternoon. Today I'll be presenting an update on 2022 Southern Hemisphere influenza surveillance in sentinel countries. The surveillance data will be coming from WHO's FluNet system, which is made mostly of data coming from influenza sentinel surveillance systems, but also includes non-sentinel data. Sequencing data comes from GISAID. So I'd first like to orient you to the data figures I'll be sharing with you for each country. On the right top panel, you can see pre-pandemic historical data in gray, which are the proportion of specimens testing positive for influenza from 2011 to 2019. The dotted red line is the epidemic threshold above which countries are considered to be experiencing their seasonal epidemic, again based off of these 2011 to 2019 historical data. The dotted green line represents 2021 data, and the bold green line represents 2022 data. In the lower panel, you can see 2022 virus data by type and when available by subtype and lineage. Influenza A viruses are in the blue and green, and influenza B viruses are in the red and orange. So starting with Australia, Australia's Southern Hemisphere season started and ended earlier than in pre-pandemic seasons, starting in the month of April and as of now ending in Epi Week 35 in August. Typed specimens so far have overwhelmingly been influenza A, with H3N2 making up 91.3% of subtyped specimens. As far as the dominant clades of circulating influenza viruses, these are based off of sequencing of specimens from July of 2022. The H1 pandemic 09 dominant clade was the 6B.1A.5A.2. H3 was 2A1B.2A.2, and B Victoria was V1A.3A.2. These dominant clades for H1, H3, and B Victoria are consistent with dominant clades that we're seeing in other Southern Hemisphere countries. Next slide, please. Australia's Department of Health and Aged Care issues a biweekly surveillance report that includes antigenic characterization of influenza isolates. Its WHO Collaborating Center characterized 2,570 isolates for antigenic similarity to their corresponding vaccine component. As you can see, they found that 92.4% of influenza AH1, 94.5% of influenza AH3 isolates, and all 6 influenza B Victoria isolates characterized the year to date were antigenically similar to corresponding vaccine components. They don't yet have influenza vaccine effectiveness estimates, but do report from preliminary data in 2022 that VE is on the lower end of the moderate range. Next slide, please. Moving on to Chile, they experienced quite an atypical influenza season in 2022, starting with influenza cases increasing during Northern Hemisphere months in January through February, followed by a more traditional Southern Hemisphere season in May through August. The season doesn't seem to be coming to a close, though, with the proportion of specimens testing positive increasing as of Epi Week 40. As is the case in Australia, most circulating viruses have been influenza A, with H3 making up over 99.8% of subtyped specimens. The dominant clade data is only for H3 as of June 2022, and they report the same dominant clade as in Australia and other Southern Hemisphere countries. Next slide, please. We've been fortunate to be working closely with Chile's Ministry of Health, Institute of Public Health, and the Pan American Health Organization on a summary report of their 2022 season, including influenza vaccine effectiveness. By the peak of influenza activity in 2022, Chile had successfully vaccinated 92.5% of persons in their priority groups. Their SARI Sentinel data submitted to PAHO's network for the evaluation of vaccine effectiveness in Latin America and the Caribbean influenza, or REVLAC-E, were used to estimate this vaccine's effectiveness in preventing influenza hospitalizations, and they found that VE against influenza A H3N2 associated hospitalizations was 49%. Next slide, please. The last country I'll share data on is South Africa, who, unlike the other two countries I just showed, have presented a more typical influenza season as compared to historic trends. Their season started in April and has declined in recent weeks. However, unlike Australia and Chile, South Africa has seen high levels of AH1N1 pandemic 09 during peak activity, corresponding to over 50% of their subtyped specimens. The later part of their season now seems to be mostly dominated by H3N1 Victoria. Information on dominant clades are from sequencing data in June and July of 2022 and show the dominant clades are the same as in other Southern Hemisphere sentinel countries. And next slide, please. So in summary, Southern Hemisphere countries have seen abnormal activity in 2021 and 2022 with shifted timing of epidemic as well as changes in the magnitude. However, influenza activity has resumed in these sentinel countries following disruptions and changes in transmission during the COVID-19 pandemic. These countries have seen mostly influenza A H3N2. However, South Africa did report significant circulation of AH1 and B Victoria viruses. Next slide, please. And I'd like to thank a number of people, but specifically would like to extend a lot of thanks to the Chile Ministry of Health, Institute of Public Health, and PAHO for their collaboration on a report for the 2022 influenza season, which we hope will be published to MMWR shortly. And with that, I'll end. Thank you.
Thank you. This presentation is now open for any questions. I'm going to ask the committee to keep it a little bit brief because we're heading towards the end of the day. All right. Ms. Stinchfield.
Hi, Patsy Stinchfield, representing NAPNAP. Thank you so much for these presentations. And to all of your respiratory surveillance team, please do know we use this data quite a bit out in the field, in the media, et cetera. I just wondered if you have considered on the pediatric influenza death data, doing a similar graph or data collection related to COVID, and then also potentially for RSV as we anticipate the future RSV products. So wondered if you've given that any thought.
That actually is the responsibility of another group here at CDC, but I think similar information would be helpful, yes.
Thank you.
Thank you. I don't see any other hands raised for the moment. Thank you. We will go on to the last presentation for this section on influenza vaccine effectiveness. Ms. Chung, Olson, and Dr. Lewis.
Hi, thank you. Can you hear me, Dr. Lee?
We can, thank you.
Wonderful. Good afternoon, everyone. My colleagues and I from the Influenza Division at CDC will be presenting flu VE estimates from last season, the 2021-22 season, using data from 3 VE platforms in the outpatient, ambulatory, emergency department, and inpatient settings. Next slide, please. You can go one more. Thank you. First, I'll present estimates from the outpatient setting among patients aged 6 months and older from the U.S. Flu VE network. These estimates were presented preliminarily at the June ACIP meeting, although we're presenting different age groups today for the purposes of comparison with the other two networks. Next slide, please. The Flu VE network in the 2021-22 season included outpatient clinics, including emergency departments at the 7 locations shown here on this slide. Next slide, please. As a reminder of the Flu VE network methods, we enroll patients aged 6 months and older who present to outpatient clinics or EDs with ARI that included fever or cough. We enrolled patients up to 10 days after illness onset, but limited our analyses here to those who enrolled within 7 days. We enrolled between October and April last season. We utilized a test negative design with persons who tested positive for SARS-CoV-2 excluded from Flu VE estimates. Vaccination status was defined as receipt of 1 or more doses of any influenza vaccine using documented sources in addition to self-report. We adjusted our estimates presented today for the factors shown here on this slide. Next slide, please. All flu viruses detected in the Flu VE network in the 2021-22 season were influenza A viruses, with nearly all being A, H3, and 2 viruses. Here we present VE against A, H3, and 2 viruses overall, which was 36%, and by age group. VE among children was 45%, and VE among adults was 28%. We enrolled a very small number of cases among persons age 65 and older, and were not able to calculate an adjusted estimate for that age group. Unadjusted VE was 32% for those aged 65 and older, and the estimate was not significant. A subset of our H3 and 2 viruses were genetically sequenced, and all the viruses belong to a genetic group with antigenic differences from the vaccine strain. Next, I'll turn the presentation over to my colleague, Sam Olson.
Thank you, Jessie. Hi, I'm Sam Olson, and I lead the flu portion of the New Vaccine Surveillance Network. We are in the early stages of calculating vaccine effectiveness against influenza-associated emergency department visits and hospitalizations among children 6 months to 17 years of age. We're working on cleaning these data, and it's a top priority for the network to finalize and publish these results. So today I'll present our preliminary estimates. Next slide. This is a map of our 7 MVSN sites. These are the same sites that were included in our last published MVSN Flu VE estimate during the 2019-2020 season that was presented to ACIP and published in CID. Next slide. To briefly describe our methods, we enrolled children 6 months to 17 years of age admitted to the hospital or emergency department with acute respiratory illness within 10 days of illness onset. Our flu season ranged from the end of November to early June, and we used a test negative design using both clinical and research testing to compare vaccination odds in our flu positive cases to our flu negative controls. And because of biases previously mentioned, we excluded those testing positive for COVID. To be considered vaccinated, patients received at least 1 dose of any flu vaccine according to medical records, registries, or self-report. And currently, we do not have the sample size to look at 2 doses in the younger children, but we will continue to look at this before we publish. And for our logistic regression model to calculate VE, we adjusted for site, age, and calendar time. Next slide, please. Here are our preliminary estimates among children 6 months to 17 years in the inpatient and ED setting. The vaccine effectiveness was 30%. When we looked at those admitted to the emergency department, we calculated a VE of 19% with the estimate crossing the null. And among inpatients, we observed a VE of 31% with the estimate crossing the null. And now I'll pass the presentation to Nathaniel, who will share the IV results.
Much, Sam. So as Sam mentioned, this is specifically a network focusing on adults who have been admitted to hospital with acute respiratory illness. Next slide, please. So this network, the IV network, consists of over 20 large medical centers, usually those associated with academic institutions as well. This particular analysis focuses on 16 of these sites, which are shown here on this map. Next slide, please. So the methods used for analyses in this network will be familiar to many of you who work in flu and other respiratory illnesses. As I mentioned, this is specifically focusing on hospitalized patients aged 18 years or older, admitted with acute respiratory illness, and tested within 10 days of illness onset and admitted to hospital within 14 days of illness onset. The dates for this analysis period are sort of well into the middle of the previous flu season. So basically comprising the first half of 2022. As I mentioned, this is a sort of familiar test negative case control design in which we're comparing odds of vaccination among those who test positive for flu versus odds of vaccination among those who test negative for flu. Vaccination status was determined as receipt of at least one dose of any of the seasonal flu vaccines. And this was based on source documentation primarily, either in the form of medical records or immunization registries, and secondarily by self-report. If source documentation was not available, though self-report alone accounted for less than 5% of participants. For analysis, we calculated VE, again, as 1 minus the adjusted odds ratio times 100%, with logistic regression models adjusting for study site, age, sex, race and ethnicity, and calendar time. Next slide, please. So as you can see here, a familiar trend in that low VE was observed, low VE against hospitalization was observed both overall, so among everybody age 18 years or older, which comprises everybody in the study, as well as when broken down by specific age groups. All of the VE estimates cross the null, essentially suggesting null to very low VE. However, of note, when we break out specifically immunocompetent adults, we did see more moderate VE of 50% in adults aged 18 to 64 years, and an estimate which did not cross the null. Next slide, please. So basically, looking at all three of these networks, sort of in comparison and contrast to one another, sort of gives us a more robust, bird's eye view of VE during the previous flu season. So if I could have the next slide, you can see in these VE plots, we've specifically organized by age group, and then looking at the different settings within each age group. So first, outpatient as represented by the flu VE network, ED and inpatient as represented in NVSN, and then specifically inpatient alone as represented by IV. So looking at all of the estimates across all three networks, we again do see very low VE. This is consistent with previous seasons in which H3N2 had predominated. I forgot to mention, but the IV network analysis where sequencing was done on 129 specimens also showed that all of them were H3N2 virus. So this is this is typical. However, we do see higher VE in outpatient settings as opposed to ED or inpatient settings. Interestingly, thinking about the IV network results, if we're looking at immunocompetent patients alone, we see that VE of 50% for 18 to 64-year-olds. If we put this in contrast with, outpatient VE for the US flu VE network, it's sort of in line with what we might expect, where we see higher VE for the more severe outcome. So putting these estimates in opposition to one another sort of allows us to tease out some of those differences. If I could have the next slide. So to summarize, we can say that influenza vaccination provided low to non-significant protection against influenza in a season where AH3N2 predominated. This was similar across pediatric ED visits, pediatric hospitalizations, and adult hospitalizations, though we did see low to moderate VE in outpatient settings, as well as when looking specifically at immunocompetent hospitalized adults aged 18 to 64 years old. This is similar to previous seasons where H3N2 predominated. And again, we see higher VE in outpatient settings, and looking across all three networks allows us to sort of think through some of these differences and why they might exist. Thanks.
Thank you very much. This presentation is now open for questions. I have one quick question, which is, and I might have missed this, so my apologies. Do you know what proportion of adults 65 and older received a higher dose vaccine?
I can say for the IV network, it's about essentially 95% about of older adults receive some sort of enhanced vaccine, whether higher dose or adjuvanted. And conversely, those under 65, about 95% are receiving the standard vaccine.
And for the flu VE network, the outpatients, for the 65 and older group, about 80% of 65 and older people received high dose or adjuvanted. Only 14% of that age group received standard dose IIV4, egg-based.
Thank you. Dr. Paling?
Thank you for these great presentations. It's really important to study flu every year. And I wanted to ask, do you have a sense of vaccine coverage by age group in the population so that we understand that perspective? Thank you.
Yeah, for the flu VE network, our vaccine coverage among controls is what we would kind of look at for that. In our enrolled population, overall last season, it was about 60%. And when we compare that to what is observed in the community reported by CDC, it's a little bit higher for adults compared to the community, and maybe a little bit lower for kids in those communities. So maybe on average, similar.
Ms. Bata?
I don't think I have a question. I just want to lament. This is really discouraging data. And I think even more discouraging is the lack of efficacy against hospitalization. And I know we can't solve this, but I think we just really need to take note and somehow send a message that we need to be finding better products.
Thank you. Dr. Long?
Thank you for that. I agree with you entirely. It seems to be on the way down annually, and I'm sure the work group has considered this notion with some evidence that repeated immunizations may be disadvantageous. So I wonder about that. Yeah, people are surprised about that, but there's the thought about, I'm not going to say this immunologically correctly, but what it is that you have seen this before your immunologic system, so you can see certain antigens or certain epitopes or acts in a way that has to do with your original influenza infection or vaccine, and that it may cause interference with the organism being seen. So I'm sure you're thinking about this and looking at this, but it is, since you commented, I mean, we can't just say year after year, this is a good thing and everybody needs to get influenza vaccine and have a decreasing efficacy and effectiveness.
Thank you. Dr. Cotton?
I just wanted to say that this is not as, the vaccine efficacy is not what we would hope it would be, but I would still say that I often view vaccines to be like seatbelts. It's much better to have a vaccine than to not have any vaccine. And we're looking specifically at measured disease incidence and hospitalization. But if you think about it, for all of us who maybe haven't had influenza for the past few years because we've been masked, there are a lot of ramifications of not developing influenza, not having influenza in your home. And when we can decrease the risk of disease, even if it's not as much as we might have hoped for, I still think that there's a pretty positive impact from vaccination. And Dr. Long, I don't know if scientific data within the influenza vaccine field, that concept of what I understand to be antigenic sin has been more discussed with COVID, but I don't know it to be true with influenza. I don't know if there are other experts in the room. But before we push forward that idea that repeat influenza vaccine could be dangerous, I think we want to make sure there's pretty robust science behind that.
Thank you, Dr. Talbot.
Yeah, I can probably talk to that. And so the idea of imprinting is the first flu that you saw as a child, presumably, because most people get infected fairly early, is what your body responds to the most. So the population who's at highest risk for flu disease right now is imprinted with H1N1, which means they are more likely to get sick from H3N2. So when we have H3N2 seasons, we typically see much lower VE just because this population was imprinted with H1N1. That being said, we had a mismatch this year, which complicates an already lower VE to an even lower VE. So the hope is we have the right strains for this year, and we are actually seeing a mix of H1 and H3, at least in Tennessee at this point, and so I think it'll be very interesting to see what this year's are. But yes, what you saw as a child has great impact on how you will do as an older adult.
Thank you. Dr. Long, your mic is on. Did you want to say anything else? No? Okay, thank you. Dr. Anderson.
Hello, Dr. Anderson from PIDS. Question would be related to the timing of the influenza season. It's very likely that there may have been some waning of the immune response that may have happened for many of these infections, which likely were happening March, April time period. And I was wondering the extent to which that could be adjusted for in the analyses that were performed and how that did impact the overall vaccine effectiveness. Thanks.
Yeah, that's a great question with the extended flu season, and I can speak to that a little bit from the Flu VE network perspective. One thing that we did to sort of look at this was to go back to our mid-season estimates and remove persons who tested positive for SARS-CoV-2 and came up with a very similar estimate to what we observed when we looked at the whole time period. So we're not sure that waning is really the biggest factor for our lower than we would like VE estimates, but it is something to consider.
Thank you very much. I do not see any additional hands raised, so I would like us to move on to the last two sessions of the day. We have a dengue vaccine session and a monkeypox vaccine session. If we could please pull up this, magic. I'd like to turn the floor over to Dr. Wilbur Chen, who will provide an introduction, an overview on today's session on dengue vaccines.
All right, congratulations to me for leading the penultimate, session for the October meeting. So let's go to the next slide. So these are dramatic pictures that are meant to convey the image that climate is going to continue to, we think, increase dengue incidence. Humans, I say, continue to encroach on kind of natural habitats, and we'll continue to expect to see increases in possibly Ebola, monkeypox, malaria, arboviruses in general, as we continue to progress through humans encroaching into nature and also having climate interact with our space as well. Next slide. So just to remind you that Dengue Vaccines was licensed in 2019, and the ACIP provided recommendations just last year. This is a vaccine that is a 3-dose regimen that is given at 0, 6, and 12 months in children who are 9 to 16 years of age with laboratory confirmed previous dengue infection, and these children are children that are living in endemic areas with dengue. Next slide. So the dengue work group recently reconvened. We've been reactivated, and we're reviewing now a new dengue vaccine, which is Takeda's TAK-003 candidate vaccine. It's a vaccine that's completed phase 3 trials. The plan is for us to present the safety and efficacy data in the February ACIP meeting. Next slide. So our work group has an agenda of course, we've been reconvened since August 30th of this year. We have been reviewing our own kind of work group schedule, and we are formulating and going through the PICO questions and reviewing right now the vaccine safety and efficacy data as we speak. Next slide. So presentations today, we plan to have Dr. Laura Adams present the dengue epidemiology to reacquaint us with this particular pathogen, and then Dr. Paz Bailey will provide us an update and an overview of Dengue Vaccines, basically the safety, efficacy, and implementation that we had planned in Puerto Rico. Next slide. So I just wanted to thank my work group colleagues, my ACIP co-members, Drs. Palin, Bell, and McNally, my co-leads, Drs. Paz Bailey and Adams, and then all the other ex officio members, consultants, liaisons, and many CDC contributors as well. So thank you very much.
Thank you, Dr. Chen, and we'll now turn the floor over to Dr. Adams. If we can please switch the slides, thank you.
Good afternoon, and thank you, Dr. Chen. Today I'll be going through a brief background of dengue epidemiology, both globally and in the US. Next slide. This is an outline of what we'll cover today, which includes routes of transmission, clinical spectrum, global burden, and epidemiology in the US, including both endemic and non-endemic areas. Next slide. Dengue is caused by dengue viruses 1 through 4, sometimes called serotypes, all of which can cause disease. Infection with the dengue virus leads to lifelong type-specific immunity against the infecting dengue virus and short-term cross-protective immunity to the other dengue viruses, usually for about 1 to 3 years. Next slide. Dengue is primarily a mosquito-borne disease spread through the saliva of infected mosquito bites. Aedes aegypti is the most common vector, shown on the top right. However, Aedes albopictus, shown on the bottom, can also sustain transmission. Other modes of transmission for dengue virus are less common, but include vertical transmission from a mother to a baby, blood transfusion or organ transplantation, needle stick, mucocutaneous exposure, or hospital or laboratory accident, breast milk, and rarely sexual transmission. Next slide. Let's move on to the dengue clinical spectrum. Only about 1 in 4 dengue virus infections are symptomatic, with the majority of infections asymptomatic or subclinical. Dengue often presents as a mild, undifferentiated febrile illness with the common symptoms shown in the image on the right, including fever, aches and pains, nausea or vomiting, and rash. Mortality among symptomatic dengue cases ranges from less than 1% if treated appropriately to up to 15% if untreated. Next slide. Dengue can progress to severe disease in about 1 out of every 20 symptomatic dengue patients and requires close clinical management. Severe dengue is characterized by severe plasma leakage, severe bleeding, and severe organ impairment. The image on the right shows a hospital chapel converted to a dengue ward to help care for patients during an outbreak in Honduras during 2019. Next slide. Many factors can affect an individual's risk for severe dengue. There's a known risk by age, with particularly higher risk among infants born to seropositive mothers, as well as elderly populations. The number of dengue infections and the time between those infections can also play a role. Although severe dengue can occur during any dengue infection, there's a higher risk on the second dengue infection compared to the first, third, or fourth infection. And last but not least, underlying comorbidities can also be associated with worse outcomes, including asthma, diabetes, obesity, hypertension, and the other conditions listed here. Next slide. It's important to understand the changing risk for severe dengue during multiple dengue infections. In people naturally infected with dengue, there's a moderate risk for severe disease on the first infection, shown here by the person in yellow. There's a higher risk on the second infection, shown by the person in red, which is associated with antibody-dependent enhancement of disease, when heterotypic antibodies bind but do not neutralize the dengue virions, leading to higher levels of viremia and vascular leakage. After the second infection, people are at lower risk for severe disease on the third and fourth exposures, shown in green, as the immune response consists of broadly neutralizing antibodies that provide more effective protection. This level of risk has also been associated with dengue antibody titers, shown in the image on the right. Low antibody titers, shown in yellow, are associated with moderate risk, while mid-range dengue antibody titers, shown in red, have higher risks for dengue hemorrhagic fever and dengue shock syndrome. The higher level antibody titers, shown in purple and blue, are associated with lower risk for severe disease. Next slide. Let's talk briefly about global dengue burden. Dengue is the most common arboviral disease globally and causes significant disability and death. This map shows the age-standardized disability-adjusted life years, or DALYs, by country, with lower burden shown in darker blue, progressing to higher burden in red. There's generally high disease burden in tropical and subtropical areas globally, particularly in the Americas and Southeast Asia, as you can see on the map here. Next slide. Dengue incidence is likely to increase as the climate warms, both through increased transmission in currently endemic areas and secondarily through expansion of the geographic range of Aedes species mosquitoes. This figure shows the areas predicted to have environmental suitability for dengue by 2080, shown in orange and red, and indicates that over 6 billion people will be at risk, an increase of more than 2 billion compared to 2015. Next slide. Messina and co-authors mapped the global distribution and co-circulation of each dengue virus type from 1943 to 2013, shown in the panels here. With the data caveat that serotype diagnostic availability has changed over time, the detection of all virus serotypes has expanded worldwide, together with growing hyperendemicity. Until the 1980s, the majority of areas had only reported 1 or 2 dengue virus serotypes. More recently, all 4 virus serotypes frequently co-circulate. Next slide. Next, let's take a look at dengue epidemiology in the United States. Ideally, we would like to have seroprevalence data to assess risk. However, because this information is rarely available at the population level, and there are differences in case identification and reporting, we use the Yellow Book criteria to group dengue risk levels in 3 broad categories. Areas with frequent or continuous risk, which we consider endemic for vaccine recommendation purposes, include areas with 10 or more dengue cases in at least 3 distinct years over the most recent 10-year period. Areas with sporadic or uncertain risk have at least 1 locally acquired dengue case in the past 10 years, and areas with no evidence of risk have no reports of local dengue transmission. Next slide. Using the Yellow Book criteria, dengue is endemic in 6 U.S. territories and freely associated states, which include the freely associated states of Palau, the Federated States of Micronesia, and the Republic of the Marshall Islands, shown in blue, and the territories of American Samoa, Puerto Rico, and the U.S. Virgin Islands, which you can see here in green. I'm going to talk in more detail about each of the U.S. territories. Next slide. This slide shows dengue case numbers on the left y-axis and rates on the right y-axis for the 3 U.S. territories by year from 2010 to 2020. The pink lines represent Puerto Rico and indicate large outbreaks in 2010, 2012, and 2013, with a slight uptick in transmission again in 2020. The blue lines represent American Samoa, which had an outbreak in 2017 to 2018, with high disease rates for the population size. USVI, shown in the green line, experienced dengue outbreaks in 2012 to 2013, similar to Puerto Rico and with similar case rates, although a smaller population size. Next slide. Looking by jurisdiction, Puerto Rico has the largest population size among the U.S. territories and also reports the most dengue cases, accounting for more than 95% of the dengue cases from endemic areas of the U.S. during 2010 to 2020. Next slide. Historically, dengue has been endemic in Puerto Rico for many years, with periodic outbreaks occurring approximately every 3 to 5 years, as you can see in this image of suspected dengue cases by week from 1986 to 2015. Next slide. This slide shows the circulating dengue virus serotypes by year in Puerto Rico from 2010 to 2020. As you can see, all 4 dengue serotypes have been detected. However, dengue virus 1, shown in the light blue color, has been the predominant serotype, particularly during the outbreak years of 2010 to 2013, and again in the cases identified in more recent years. Next slide. When we look at the dengue cases and hospitalizations by age group in Puerto Rico, the highest burden of disease falls in the 10 to 19-year-old age groups, shown by the yellow box, who experienced higher case rates and hospitalization rates compared to other ages. Next slide. However, we see a slightly different trend among fatal dengue cases, with higher mortality rates occurring among the adult population. Next slide. And while there's a limited population level seroprevalence data, a serosurvey in 2018 assessed previous exposure to dengue and Zika viruses using plaque reduction neutralization assays among about 700 children in southern Puerto Rico. While exposure to both viruses were frequently identified, testing found that approximately 8% of children 1 to 8 years old and 44% of children 9 to 16 years old had evidence of previous dengue virus infection. Next slide. Let's move on to American Samoa. A serosurvey in 2010 among adults found that 96% were seropositive for previous dengue infection. More recently, an outbreak from 2016 to 2018 identified more than 1,000 confirmed cases. Next slide. The dengue case rates and hospitalizations in American Samoa are similar to what was seen in Puerto Rico, with the highest rates occurring among children 10 to 19 years old, shown here by the yellow box. Next slide. Dengue has also caused periodic outbreaks in the U.S. Virgin Islands, which include St. Croix, St. Thomas, and St. John. Multiple dengue virus serotypes have circulated, with the most recent outbreaks in 2012 to 2013 consisting of dengue viruses 1 and 4. A school survey in 2012 during these outbreaks found that about 20% of the population had evidence of recent dengue virus infection. Next slide. The age groups with higher dengue case rates in the U.S. Virgin Islands are also the 10 to 19-year-olds. However, the case distribution in USVI also includes a relatively larger proportion of adults compared to the other endemic areas. Next slide. To assess dengue seroprevalence among children, the USVI Department of Health conducted a serosurvey in 2022 among 372 school children 8 to 13 years old. This slide shows the prevalence of dengue IgG antibodies by age, which found that seroprevalence was greater than 40% starting at 9 years, the lowest eligible age for vaccination with the Dengvaxia dengue vaccine. Next slide. This slide shows data reported from the dengue endemic freely associated states in recent years. All 3 jurisdictions have experienced multi-year outbreaks with large numbers of dengue cases reported, with a large dengue virus 3 outbreak affecting all 3 jurisdictions between 2018 to 2021. Next slide. And we'll now briefly take a look at dengue cases reported from US states. Although dengue is not considered endemic in the states, there is a risk for local transmission of dengue because the mosquito vectors are present in multiple states, particularly in the southern United States, as you can see in the maps on the right. Most dengue cases, which is more than 94%, reported from states during 2010 to 2022 were associated with travel to endemic areas. However, there are some notable examples of continued local transmission, including outbreaks in Hawaii, Florida, and Texas. Additionally, sporadic dengue cases without a history of travel to an endemic area have been reported from other jurisdictions shown here. Next slide. This slide shows the number of dengue cases reported from US states by year to ARBONET, with more than 8,000 cases reported during 2010 to 2022. There was an average of about 665 cases annually, with a large spike in 2019 associated with multiple dengue outbreaks globally. Next slide. When we look at dengue cases by age group reported from the states, there's a higher proportion of cases seen among adults, in contrast to the primarily pediatric population in endemic areas. Next slide. And this slide shows the dengue virus serotype identified among reported cases. Dengue virus 1 was the most frequently identified serotype among cases with a serotype information available. Next slide. And finally, this slide shows the most frequent regions of travel among travel-associated dengue cases. Dengue cases were identified from endemic regions globally, although the most frequently reported locations included the Caribbean and Asia. Next slide. In summary, dengue is a public health problem throughout the tropics and subtropics, including the Americas. Dengue is considered endemic in 6 US territories and freely associated states. In those endemic areas, the highest burden of disease occurs among the 10 to 19-year-old age group, although many cases and a higher fatality rate occurs among adults. In the US states, most cases are associated with travel to endemic areas, although sporadic local dengue virus transmission has been documented in Florida, Texas, and Hawaii. Thank you. And I'll now pass it over to Dr. Paz Bailey to provide an update on dengue vaccines, and we're happy to take questions on both presentations at the end.
Thank you so much,
Thank
Dr.
you.
There we go. Thank you.
Yes, thanks. Good afternoon. My name is Gabriela Paz Bailey, and in the next 10 minutes, I will be providing a summary of Denvaxia efficacy and safety data and where we're at with implementation in Puerto Rico. And this topic is important as dengue is the most common arbovirus globally. And as you have heard in the previous two presentations, we're expecting that incidence will increase with increasing global temperatures. And while you listen to this presentation, I would like you to think about the lessons learned with the review and approval and implementation of the first dengue vaccine. Next slide. Thank you. Dr. Adams already presented this graphic, and I'm not going to review it in detail again, but I would like to remind you that a person can be infected with dengue multiple times in their lifetime. And after a primary dengue infection, the durable protective immune response is directed to that serotype-specific epitopes on the infecting virus, leaving individuals susceptible to a second dengue infection with a new serotype. After a second infection with a new serotype, the protective immune response is mainly directed to epitopes conserved between serotypes, and clinically significant tertiary dengue virus infections are less common. The implications for vaccines is that in those who have experienced a dengue infection before receiving the vaccine, even an imbalanced vaccine dominated by one vaccine serotype is likely to induce cross-protective immunity by activating memory. In dengue-naive individuals with no immune memory, the protective immune response to each serotype will strongly depend on how well each vaccine component independently performs. Next slide. So let's talk about the first dengue vaccine to be approved for use in the United States, Denvaxia. Next slide. Denvaxia is a tetravalent live attenuated vaccine. It is a chimerical viral vaccine on a yellow fever backbone. And the vaccine includes gene sequences obtained from each of the 4 dengue virus serotypes. Next slide. It is a series of 3 doses separated by 6 months each, which means that a full year is needed to complete the series. Next slide. And I would like to review a few events in the history of Denvaxia. The phase 3 trials were published in 2015. The findings showed increased risk of hospitalization and severe disease among vaccinated children ages 2 to 5 years. Because of that, the vaccine was recommended by WHO in 2016 for persons 9 years of age and older, and to be used only in highly endemic areas. Sanofi eventually found that the increased risk of severe disease and hospitalization was associated with serostatus, meaning if the child had previous dengue infection or not before receiving the vaccine. And those without previous dengue infection or naive were at higher risk if vaccinated. After this, WHO revised their recommendations, stating that the vaccine should only be given to children with laboratory confirmed evidence of a past infection. Next slide. I will now review the vaccine efficacy data. Next slide. Denvaxia protects persons aged 9 to 16 years with a previous dengue virus infection against dengue, hospitalization, and severe disease. The vaccine efficacy was 82% for symptomatic disease, 79% for hospitalizations for dengue, and 84% for severe dengue. Next slide. Denvaxia protected against all 4 serotypes in these children, but to different levels. For the outcome of symptomatic dengue, for example, it had higher efficacy of 80% against dengue 3 and 89% against dengue 4, but lower efficacy of 67% for dengue 1 and dengue 2. Next slide. I will now review vaccine safety data. Next slide. Post-trial analysis showed higher risk of hospitalization and severe disease following vaccination in seronegative children aged 9 to 16 years. In seronegative children, the efficacy against symptomatic disease was 39%. Against hospitalization, it was negative 41% and negative 144% against severe dengue. Please note that these estimates suggest an increased risk, but confidence intervals do cross zero. Next slide. The most common side effects within 14 days following vaccination include headache, injection site pain, myalgias, malaise, and asthenia. And there was no difference between the placebo and the control arms. Next slide. So after FDA approval in 2019, the ACIP reviewed all of this data and unanimously recommended it for routine use on June of 2021. And in the recommendation, they noted that it should only be given to children 9 to 16 years old who have laboratory confirmation of previous dengue virus infection and that live in endemic areas in the US. Next slide. Since many dengue infections are asymptomatic or do not result in a medical visit during the acute phase of the illness, most children will need to have laboratory testing done before they receive the vaccine. The test will need to be highly specific to avoid vaccinating a child without previous dengue virus infection. And the recommendation from CDC are that the test has at least 75% sensitivity and 98% specificity. Next slide. CDC evaluated IgG commercially available tests and found that 2 tests were close but did not quite meet the screening criteria. Using them in combination, a specificity of 100% was reached, and the current testing recommendations are to use 2 tests in a 2-test algorithm using the Euroimmun ELISA and the CTK rapid test. And positive results are required in both tests for vaccination with Dengvaxia. Next slide. Now I would like to provide you with a brief update on dengue vaccine implementation in Puerto Rico. Next slide. In Puerto Rico, there are 280,000 children eligible for Dengvaxia. Next slide. Dengue vaccine acceptance has increased after the availability of COVID-19 vaccines. And this analysis is using data from a cohort in southern Puerto Rico. Responses were divided into 2 time periods, pre-COVID and post-COVID. Pre-COVID refers to the time before COVID-19 vaccines became available in Puerto Rico and includes interviews conducted from May of 2019 to December 14th, 2020. And post-COVID refers to the time after the COVID vaccines became available in Puerto Rico, which was from December 15, 2020 until the end of December of 2021. The light purple bar indicates that before COVID-19 vaccines became available in Puerto Rico, 73% of adults intended to get the dengue vaccine, and this increased to 85% once COVID-19 vaccines became available. The next slide. Similarly, when asking them about intention to vaccinate their children, the proportion reporting yes went from 76% pre-COVID to 86% post-COVID. Next slide. This is one of the first vaccines to require laboratory testing to determine eligibility. The laboratory test requirement has implications for vaccine logistics. Because of this test, multiple visits to healthcare providers and the lab will be required before giving the first dose, as you will see in this diagram. Can you click again, please? First, the children will have to be evaluated by their pediatrician, who will order the pre-vaccination screening test. Click again. Next, they will have to go to the lab to do the test or phlebotomy can be conducted at the clinic and the specimen sent to the lab. Click again. Then they will have to return to the pediatrician to interpret the results and order the vaccine. Click again. Finally, they will proceed to the vaccine clinic and receive their first dose. And last click for this slide. And then they will schedule their second and third dose. So you can appreciate here that this process of starting the vaccination can take several weeks and that the logistics of vaccination are a challenge to vaccine implementation. Next slide. Despite these complex logistics, vaccination with Denvaxia has started in Puerto Rico. This picture here is of Dr. Iris Cardona, who's the principal medical official from the Puerto Rico Department of Health, who is presiding over the first Denvaxia vaccine that was administered in Puerto Rico. And currently Denvaxia and the pre-vaccination screening test is available in 4 clinics in the island. Next slide. Implementation of the dengue vaccine in Puerto Rico is planned in phases. In phase 1, 4 clinics are offering pre-vaccination screening and vaccination. And the target date to complete this phase is November of this year. In November, the health department and the immunization program will open up vaccination to all federally qualified health centers and their associated satellite clinics. And it's next, can you click again? And it's planned that in January of 2023, the Puerto Rico Health Department will move to phase 3, in which all providers, private and public, may offer the dengue vaccine. Next slide. So there have been several challenges to the implementation of the vaccine. The need for pre-vaccination screening complicates logistics, as shown before. The tests used are not FDA approved and are implemented under CLIA protocols. Puerto Rico has a local regulation that all testing needs to be done by a licensed laboratory technician, and therefore tests can rarely be implemented as point of care. The public messaging on a vaccine to prevent dengue among those who have had dengue before can be challenging. Insurance coverage for the test has been complicated by lack of a specific billing code, but it was recently resolved. And there have been competing priorities like COVID vaccination. Next slide. There's a new dengue vaccine from Takeda that the work group has started reviewing. Next slide. TAC-003 is a tetravalent live attenuated vaccine on a dengue 2 virus backbone, expressing proteins of all 4 dengue serotypes. And the schedule has 2 doses that are administered 3 months apart. Next slide. On October, please click again. On October 13th of this year, the European Medicines Agency recommended the approval of Takeda's dengue vaccine for the prevention of dengue disease caused by any serotype in individuals 4 years of age and older. The review was for the European Union and non-EU countries under the EU Medicines for All procedure. And this procedure allows regulators in other countries to rely on the EMA scientific assessment to decide on the use of the vaccine in their countries. And the final step in Europe is marketing authorization from the EMA that is expected in the next months. The vaccine has been approved for use in Indonesia, and the company has plans to submit to regulatory agencies in other countries. Click again. One more. Thank you. Next slide. In summary, the Denvaxia vaccine has an efficacy of 80% among seropositive children against symptomatically virologically confirmed dengue, hospitalization for dengue, and severe dengue. Click again. Implementation has been challenging due to the pre-vaccination screening requirement, the 2-test algorithm, and also the reimbursement procedures. And one more click. The dengue vaccine work group has started review of the Takeda TAC-003 dengue vaccine. Next slide. And I would just like to acknowledge the work of the ACIP dengue vaccine work group. Thank you. We can now answer any questions.
Thank you. These 2 presentations are now open for questions. Dr. Cotton.
Thank you for the presentations. Given that both Denvaxia and the Takeda vaccine are live viral vaccines, could either one be used in immunocompromised? They're replicating, correct?
Yes, and the recommendation is that it can be used among immunocompromised patients with CD4 counts above 200, but not in severely immunocompromised children.
So that's for, to clarify, that's for HIV, but not other immunocompromised, potentially? Or we don't know yet? Okay, thank you.
I don't see any other hands raised. One quick, I'm assuming the testing algorithm would also apply to the Takeda vaccine, is that correct? Or is it not, is that an assumption that I shouldn't make? Okay. I think that,
no, we have just started reviewing the Takeda vaccine. So no, we do not know yet.
Thank you. Okay. I don't see any other hands raised in the room. Thank you very much for those presentations, and it's really great to see the update on what's happening, and congratulations on the implementation. It looks like it just launched last month, so that's pretty huge because it took a lot of planning to get that in the works. So thank you again for protecting kids against dengue. We will now move on to the last session of the day, which is the monkeypox vaccine session. I'm going to turn it over to Dr. Pablo Sanchez, who is the chair of the newly formed Monkeypox Vaccine Work Group, and he'll provide an overview of the work group's terms of reference. Thank you.
Thank you, and good afternoon. So I'll be speaking on the Monkeypox Vaccine Work Group. Next slide. So monkeypox is a rare but sometimes life-threatening zoonotic infection. It's endemic in parts of West and Central Africa, caused by the monkeypox virus, which is an orthopox virus. It can spread from infected animals to people and then person to person through respiratory secretions, skin-to-skin contact with infected body fluids, as well as through fomites. Next slide. In 2021, the ACIP recommended the use of orthopox vaccine, the new product Jynneos, which was licensed by the FDA in 2019 for pre-exposure vaccination of people at occupational risk for orthopox virus exposures. The work group meetings were conducted from 2019 to 2021. The recommendations were published in June 3rd, 2022 in the MMWR, and the first authoring was headed by Agam Rao, our superb CDC person, and also the work group was also headed by Beth Bell from the ACIP. Next slide. So the ACIP votes about primary vaccination with Jynneos was that the use of Jynneos vaccine as an alternative to ACAM 2000 for research laboratory personnel, clinical laboratory personnel performing diagnostic testing for orthopox viruses, and for designated response team members at risk for occupational exposure to orthopox viruses. And they also recommended the use of Jynneos based on shared clinical decision-making as an alternative to ACAM 2000 for healthcare personnel who administer ACAM 2000 or care for patients infected with replication-competent orthopox viruses. Next slide. So Jynneos, the Jynneos vaccine is an attenuated, non-replicating live virus vaccine produced from the modified Vaccinia and Cara Bavarian Nordic strain. It was licensed by FDA in September of 2019 for prevention of smallpox and monkeypox virus in adults 18 years of age or older. And it consists of a series of 2 doses administered 28 days apart. Next slide. So the standard administration for the Jynneos vaccine is subcutaneous administration with a volume of 0.5 ml. And it was authorized for people aged less than 18 years of age under the emergency use authorization. The currently recommended regimen, also recommended under the emergency use authorization, was an intradermal administration with an injection volume of 0.1 ml. And this recommendation came from results from a clinical study that showed that the lower intradermal dose was immunologically non-inferior to the standard subcutaneous dose. And importantly, it facilitated more people being vaccinated with the Jynneos vaccine. Next slide. So this is the outline of the outbreak that was predominantly associated with men who have sex with men and their contacts. So the outbreak began on May 16th, 2022. There were 4 cases in the UK among men who have sex with men. On May 17th was the first United States case that was identified. And then there was a large global increase in cases, including in countries where monkeypox does not typically occur. The World Health Organization on July 23rd declared monkeypox as a public health emergency of international concern, and this was followed on August 4th by the United States declaring a public health emergency. On August 19th, the U.S. had the peak number of cases in the United States, and the cases subsequently have been decreasing but are still occurring. Next slide. And so here you see on the graph the number of cases that have been reported to the Centers for Disease Control since the start of the outbreak. The case, as I mentioned, case counts decreased after the peak on August 9th, 2022. Male-to-male sexual contact has been the most common, but there have been some cases reported in women and children and men who do not report recent men-to-men sexual contact. And the demographic shift has occurred as well from previously mostly white, non-Hispanic males to now many Black and Hispanic are being affected. Next slide. So as of October 11th, 2022, there have been 906,325 doses administered in 54 United States jurisdictions. As you can see on the figure there on the left in the United States, where they were states where administration has occurred, and then the dates that were administered there on the figure on the right. The next slide. So here you can see the first vaccine doses by race and ethnicity. And you can see that the majority of the doses have been provided to white, non-Hispanic, and subsequently followed by Hispanic, Black, non-Hispanic, and Asians. Next slide. So the Jynneos vaccine, as I mentioned, was approved for prevention of smallpox and monkeypox disease. The primary vaccine that's being used during the current outbreak and was recommended by ACIP for primary vaccination and booster doses for certain people at occupational risk for orthopox virus infections. On the other hand, ACAM 2000 was approved for prevention of smallpox disease, and it is an alternative to Jynneos and was recommended by ACIP as primary vaccination and booster doses for certain people at occupational risk for orthopox virus infections. Next slide. So the components of the U.S. national monkeypox vaccine strategy has been, first of all, post-exposure prophylaxis, then expanded post-exposure prophylaxis. And what we're really focused now has been on the pre-exposure prophylaxis, or PrEP. Next slide. So the U.S. government interim recommendations for monkeypox virus pre-exposure prophylaxis has centered on people in certain occupational risk groups: gay, bisexual, and other men who have sex with men, transgender, or non-binary people who in the past 6 months have had new diagnosis of one or more national reportable sexually transmitted diseases, who have had sex with more than one sex partner. People who've had any one of the following in the past 6 months: sex at commercial sex venue, sex in association with large public events in geographic areas where monkeypox transmission is occurring. Then sexual partners of people with the above risk factors, and people who anticipate experiencing above risks. Next slide. So the work group, terms of reference, the purpose of the work group has been during May 2022, a global monkeypox outbreak began, predominantly affecting men who have sex with men. The work group will review available data to inform monkeypox vaccine policy, including recommendations for use of these vaccines in the U.S. population during the ongoing outbreak. The topics under discussion include review the epidemiology of monkeypox virus infection in the United States, evaluate the safety and effectiveness of vaccines licensed to prevent monkeypox, assess risk-benefit balance for use of vaccines during an ongoing outbreak, identify areas where additional data are needed to inform recommendations, and develop monkeypox vaccine policy options. Next slide. So the first workgroup topic that we are working on is to further consideration of populations for which JYNNEOS monkeypox virus vaccine should be offered as pre-exposure prophylaxis. Next slide. And the data to be reviewed by the work group include public health problem, vaccine effectiveness for subcutaneous and intradermal administration, vaccine safety for subcutaneous and intradermal administration, values and acceptability of vaccine to affected population, feasibility and resource use involved in PrEP expansion, health equity considerations, as well as a timeline to be determined. Next slide. So with that, I'd like to thank Beth Bell, work group member, as well as ex officio liaison members, as you can see here, with ACOG being represented by Howard Minkoff. And I also like to point out Jafar Razek, who's been also very helpful both in the initial as well as the current work group. We have invited consultants, Stuart Isaacs is among them, an expert on smallpox and monkeypox. Next slide. And then we also have a number of STI, HIV, and monkeypox and adult and pediatric consultants, immunization and vaccine safety consultants, health equity and vaccination strategies, as well for smallpox, occupational medicine and worker safety consultants and experts. Next slide. And then very much want to thank our CDC contributors, Brett Peterson, and certainly Agam Rao, who is the current expert, in my opinion, of monkeypox. And she's really leading, doing a superb job in leading the group. Thank you.
Thank you, Dr. Sanchez. This presentation is now open for questions. Dr. Shah.
Great. Thanks, Dr. Sanchez. One of the topics that states have been discussing is whether or if moving back to subcutaneous administration is something that ought to be considered. The initial move, as you're aware, to intradermal was because of limited vaccine availability. The question on the table from an implementation perspective is now that our teams are used to intradermal administration, now that the population most at risk is sensitized to the benefits of it, whether it's worth it to shift back or stick with the status quo. So we would appreciate any insights from the working group now or at the appropriate time, given that the hour is late.
Thank you, Dr. Shah. This is Agam Rao. We are talking about that. We've been discussing the VE data that's available. There's going to be more VE data and safety data comparing the intradermal and the subcutaneous route, and so the work group will consider all of these things when we come back to present to the ACIP.
No, and I just want to add that that we are discussing it, and the question is also how practical it is to give the intradermal, how easy it is compared to the subcutaneous. So I think, although, as Agam said, I think that has come up, and we're hoping to also have some presentations about the effectiveness of both methods.
Thank you. Dr. Shen?
Yeah, this was actually piggybacking off of Dr. Shah's question, which is, I didn't know what proportion of that 906,000 doses were given ID versus subcutaneously, and then kind of wondering, are we going to be able to assess in some way the durability of protection by the two routes? Kind of also trying to inform, you know, the route of administration for in the future.
Yeah, thanks, Dr. Chen. So that actually does reflect a lot that was given subcutaneous early on in the response, and it actually reflects a lot of post-exposure prophylaxis and PEP++, or the expanded PEP. We are working to trying to break it down by how much has been given by both methods, and over time we're hoping that that graphic will actually represent more pre-exposure prophylaxis and can provide you with that data in the future. As far as your second question about, I think are you asking about like duration of immunity from the vaccination? So we are actually trying to collaborate with some academic partners to evaluate like the immune response after someone has monkeypox, the duration of protection, so that we can understand when they might need to be vaccinated, if they need to be vaccinated, and also the duration of the immune response from after having received the Jynneos vaccine. We do know from having presented the systematic review data, the grade data last year, that the subcutaneous route, we know that there's an anamnestic response at least at 2 years after completion of the 2-dose series. And based on Dr. Fry's data, we assume that the intradermal route is going to be similar, but are going to follow it forward, not just at the 2-year point, but going beyond that to inform guidance in the future.
Thank you. Are there any other questions? I was going to ask about your, if you have any plans to publish or present some of the data around, I'm thinking about our youngest kids, and the utility or the benefit-risk balance of vaccine use, of course, dependent on the context of the exposure. But it'd be really helpful, I think, to have that as sort of some of a foundation to understand how to support clinical decision-making.
Yeah.
Go ahead.
I was just going to say that we do have a CDC MMWR that is planned to be published the first week of November that characterizes the it was under 100 cases. I can't remember how many cases, but it is the pediatric cases that we have been notified of since the beginning of the response up until a certain cutoff point. And it describes, it basically says that the youngest children seem to have acquired it from caregivers through contact. And the adolescents, best we can tell, seems to be similar to adults, male-to-male sexual contact. We are trying to tease that out better, actually. Transmission is a really critical question, and I know in the work group, people have asked repeatedly that just for an explanation about the cases in women, the cases in pregnant women, the cases in children, just to understand what we can say about what type of exposure led to some of these cases where male-to-male sexual contact is not believed to be the cause. And so that is a priority for the response right now. And I did see some data earlier today that's not yet ready for prime time, but will perhaps be presented to the work group next week to try to tease this out. But to answer your first question about the pediatric epi, that will be published very soon.
No, and just to add that, I think it's critical that we know more about, and that's come up as to how many cases in the less than 5 years and also less than 12 months. And from my end, really important, how many neonates, because that's going to also dictate what we do for the mother at the time of delivery and the baby, and what type of care we can do or not do for that dyad.
And to go with that, is there tracking on safety of the dosing, especially in the youngest infants?
Yeah, currently there's no safety concerns that have been identified. There have been some very young people who have been vaccinated, and we haven't seen any safety concerns, but that is on the radar for the vaccine safety folks. And I'll also just say about pregnant women that we are trying to make an effort to understand the location of the lesions as well, because understandably it would affect decisions that clinicians perhaps make about the delivery. So just external versus internal, those sorts of things we're trying to investigate through some special studies.
And in addition, there will be, the plan is to have a V-safe for monkeypox as well. So that's in the works. So we should have some information as well. Yeah.
Thank you. We really appreciate your public health response on this issue. I don't see any additional hands raised. So with that, I'm going to ask Dr. Wharton if you have any additional business.
We do not. I think we can adjourn.
Any objections to adjourning? No. All right. I now call this meeting fully adjourned. Thank you, everyone, for your work over the past 2 days, and I want to thank all of our presenters, members, ex officio, and liaisons. Thank you.